Hello, my name is Aisha Johnson, and I'll be covering Chapter 7 on motivational interviewing and the treatment of depression. This chapter begins with a rationale for the use of motivational interviewing in the treatment of depression, reviewing MI as a brief standalone intervention for depression, as well as MI integrated with other treatments such as cognitive behavior therapy with behavioral activation and interpersonal psychotherapy. The focus on MI as a pre-treatment to engage individuals in treatment for their depression. It begins where the empirical evidence is strongest, MI for the treatment of depressive symptoms in the context of other medical conditions and medical settings, such as primary and chronic care. It also includes coverage of MI. There is a need to explore novel treatments and adaptations given that depression continues to be among the leading cause of disability in the United States and worldwide. Despite the availability of treatments such as antidepressant medications and psychotherapy and costly investments in clinical research, the prevalence and burdens of depression have not improved in the United States. The majority of adults in the United States with depression do not receive evidence-based depression care. According to DSM-5, depressive disorders is a category that includes a number of diagnoses in addition to major depressive disorder, premenstrual dysphoric disorder, persistent depressive disorder, substance medication-induced depressive disorder, and unspecific depressive disorders. All share the common feature of sad, empty, or irritable mood, along with behavioral and cognitive changes that significantly affect the ability to function. The authors of our book suggest that MI fits the symptoms of depression. Symptoms and features of depression, such as motivational deficits, ambivalence about change, and problematic decision making. MI focuses on supporting self-advocacy and reinforcing, which may be key to reducing symptoms of depression. MI may be used as a standalone treatment to address the symptoms of depression, particularly in populations and settings where depression is less severe, less chronic, or secondary to another physical condition. Motivational interviewing is an evidence-based style of partnering with patients that have been shown to outperform given advice. For example, although it is clear that CBT has been shown to be largely effective for depression, aggregated response and remission rates can be improved upon. Remission and response rates for IPT are similar to those of CBT. MI can be conceptually and practically integrated throughout CBT and IBT. Whenever motivationally and practically integrated throughout CBT and IBT, whenever issues arise. Therefore, enhancing CBT outcomes. Symptoms and features of depression, such as motivational deficits, ambivalence about change, and problematic decision making, are special in my focus. MI delivered in 4 sessions or less is considered a brief treatment for depression as an alternative to low intensity cognitive behavioral therapy, or as part of a stepped care approach in primary care. Much of the research to date has focused on depressive symptoms in individuals with physical health care concerns. Narking and colleagues adapted motivational enhancement therapy, MET for short, for young adults living with HIV. MET is a manualized 4-session MI-based intervention originally developed to target alcohol use. Project Match Research Group, 1997. It differs from MI in that it includes a feedback component, informing the client about where the severity of his or her problem falls as compared to others with the same problem. The Healthy Choices interventional target general health behaviors, medication adherence, substance use, and sexual risk. It consists of 4 60-minute sessions focusing on the 2 most problematic behaviors from the baseline assessment. 2 additional randomized clinical trials support the use of MI to improve depressive mood in patients with physical health concerns. A few recent studies show the need for treatment engagement, showcasing the importance of addressing motivational factors by using client-centered counseling approaches. In addition to the direct targeting of symptoms, several existing evidence-based depression treatments are ideally suited to integration with MI with the goals of improving overall treatment response rates. The 2 most commonly studied psychotherapeutic treatments for depression are cognitive behavioral therapy and interpersonal psychotherapy. Both CBT and IBT are usually time limited, up to 20 sessions, and aimed remission of target symptoms. MI may work best to build motivation for change, whereas treatments like CBT provide the skills to take action for change. There are now multiple studies suggesting that MI, in combination with more intensive treatments like CBT, is effective and perhaps more effective than a single treatment alone, though most studies target substance abuse and not depression. To our knowledge, there have been no studies combining MI and IPT. Both MI and CBT share a problem-oriented focus in which a specific goal or target behavior is the focus of the therapeutic interaction. However, to promote the engaging process when integrating MI and CBT, the target behavior is not identified as a problem per se, as that it is counter to a client-centered perspective. Rather, depression is seen as a resulting in behaviors that the client perceives as interfering with functioning. In this way, the practitioner avoids words like problem or disorder and instead reflects the client's language regarding the target behaviors emotions, or goals. In CBT, the case formulation addresses the connections between thoughts, emotions, moods, and behaviors. Case formulation guides the course of treatment by prioritizing goals and planning the choice and timing of interventions, as well as predicting possible problems. Following the assessment and case formulation, the client and practitioner collaboratively set goals and plan for treatment, consists with the focusing and planning process of MI. A more comprehensive approach involves selecting the client view of his or her situation and then placing these ideas in the content of collaborative goals for treatment. Several communication strategies can ensure that the MI process are maintained throughout the, re- the restructuring and skills training components of treatment. A primary strategy of maintaining engagement is to ask for permission before engaging in any therapeutic task. Cognitive restructuring and skills training typically involve homework assignments, such as tracking thoughts or practicing coping skills. Homework assignments are a recommended component of virtually all CBT, and homework completion has been associated with improved outcomes. The EPE approach builds motivation for homework completion by ensuring that the client agrees with the purpose of the assignment and how they are related to his or her goals. When homework is missed, a pros and cons activity may help address sustained talk. Pros of completing the assignment. If talk around homework continues to emerge, an MI approach suggests that rolling with it by allowing the client to consider alternatives and to reconsider whether the skill is important to his or her personal plan for change. Rulers may be tailored to evoke motivation for the specific skills or homework assignment. For example, on a scale from 1 to 10, how would you rate the importance of keeping a thought record at home this week? Following this question with, why did you say a 5 and not a lower number? May help to build motivation for homework. The behavioral component of CBT is commonly referred to as behavioral activation, BA, which has emerged as a standalone treatment for depression as well. BA includes functional analysis of triggers for mood and symptoms followed by interventions aimed at gradually increasing the patient's engagement and experiences, behaviors, and activities that boost positive mood and improve symptoms. A major clinical MI can be MI can be helpful in this respect. MI was developed specifically for targeting behavior change. There are a number of specific behaviors that are commonly targeted in BA, such as increasing engagement in pleasant events, exercising, changing negative interpersonal behaviors, and reducing avoidance behaviors. Avoidance of behaviors that would improve mood. Each of these behavioral change goals may be met with client ambivalence and resistance. It is here that MI may be most useful in potential decreasing ambivalence and increasing engagement in treatment. IPT emphasizes the link between depression and interpersonal relationships and functioning. Within the IPT framework, depressed patients are often lacking varied aspects of social support, owing either to interpersonal conflict, losses, or other life changes. Integration of MI therefore has the potential to enhance the effectiveness of IPT by improving adherence to specific IPT behavioral change targets, as well as by facilitating relationship problems. Given that a key focus of IPT is on improving interpersonal connection, functioning, and support, the practitioner's use of skills to promote MI spirit serve as therapeutic model for the IPT client. In fact, it may be useful for therapists specifically to teach clients some of the basic skills of MI as a way of relating to others. As with CBT, ambivalence is commonly encountering in IPT. MI can be useful to resolve ambivalence about specific behaviors and decisions. For example, in IPT, depressed mood and other symptoms may be linked to deficits or unsatisfactory social support. One target of treatment, therefore, is changing the ways in which patients communicate their needs for support to others. MI and relapse prevention. Relapse rates for depression are high. The primary model of relapse prevention comes from the addictions literature, with a focus on changing cognitions around how the client views lapses and helping the client to understand the difference between lapses and relapse. If setbacks or relapse are viewed as failures by the client, relapse is more likely to occur. However, if lapses are viewed more as learning experiences, it is more likely that relapses will be reduced and perhaps even eliminated. Furthermore, the engaging processes of MI suggest avoiding the terms lapse and relapse, and instead expressing empathy about the difficulties of maintaining changes, as well as supporting and choice with regard to maintaining behavioral change. Using terms like slips and maintenance instead of lapse or relapse prevention are preferred. MI has clear potential for enhancing depression treatment outcomes, both in terms of addressing depressive symptoms directly and brief MI and integrating MI with other psychotherapies. While several studies support the use of brief MI to reduce depressed mood in populations with physical health conditions, studies target depressed mood in other populations within primary care. Subclinical depression in the content of non-chronically ill persons and adolescents populations are lacking. Also lacking are studies of the efficacy of MI with people with primary depression who do not necessarily have any significant health problems. There are few studies addressing the integration of MI and CBT for depressed people with health-related concerns. MI has the potential for increasing motivation to exercise so that it becomes even more effective.